just to really sort of highlight what the current treatment regime is in the UK at the minute, how perhaps that might have come about, recognising that it may not be adequate for a number of pernicious anaemia patients in this country, and also what we intend to try and do about this, just to try and get some change to happen. So I'll talk a little bit about the current UK framework for prescribing vitamin B12. I'll then move on to summarise some research work that we did over this summer, looking at what really happens. So this was a survey of members of the Pernicious Anaemia Society. And then I'll move on then to say how we intend to use all of that information to try and sort of get change happening in the UK. So just to sort of explain to you what the current UK framework is with regards to prescribing vitamin B12. So first of all, with any sort of area of clinical practice, there is always some element of law that dictates what, as healthcare professionals, they can and can't do. So there's something called the Medicines Act, which was legislation back in 1968, and it is still the current bit of UK sort of regulatory medicines law within the UK. So that very much dictates who can prescribe in the UK, what can be prescribed in terms of which drugs can be prescribed on prescriptions, and also what can be purchased as well. So it gives all medicines essentially a category, whether they need to get on prescription, whether they can be sold by under the supervision of a pharmacist, or whether they're what we call general sales list medications, which are the things you can pick up in supermarkets, petrol stations and things like that. So in terms of legislation, there is no wriggle room within the UK Medicines Act. Okay? No healthcare professional can work outside of that. They wouldn't be covered. So I know sometimes people, as patients, they do find resistance when they're trying to sort of get their doctor to perhaps be slightly flexible with prescribing things. In terms of what is prescribed, they don't have any flexibility with that. Okay. So the next level is essentially sort of what governs which medicines can be used in the UK. So the MHRA, which is your Medicines and Healthcare Products Regulatory Authority, they're a big organisation based in London, and essentially they sort of issue product licences for all medicines that have licences in the UK, and they also issue licences for manufacturing units as well. So again, nothing can be prescribed in the UK unless it has a product licence. There are some very extreme circumstances, if you like, when we have perhaps supply problems where people might start importing medicines from other countries, but 99% of the time, products can only be prescribed in the UK that have a product licence. Your next level in terms of prescribing, so we know what we can prescribe. We know that hopefully the product is safe to be used in humans. The next thing is about how we prescribe things. So in what circumstances do we prescribe? And in the UK at the minute, we have NICE, so an organisation that determine certain treatments, both medicines treatments and perhaps surgical procedures and other things. So NICE very much determine when and how new drugs can be used in the UK. And they also produce guidelines for treating medical conditions as well. Now, as Martin highlighted at the beginning, we don't currently have any NICE guidelines that cover the treatment of pernicious anaemia. Obviously, there is hope that that will change in the future. But currently, there aren't any guidelines to give further guidelines for GPs in terms of, or hospital doctors in terms of prescribing in B12 deficiency pernicious anaemia. So then the next level, if you like, of framework, there may be, for some conditions, there might be specialist guidelines and recommendations. And these are sort of guidelines that are written by expert groups and committees. So for pernicious anaemia, we do have the BCSH guidelines. So these are guidelines written by an expert committee based on their opinions, but also mainly grounded in the literature and the evidence as well. The next sort of guideline that is perhaps the thing that prescribers will access and utilise on a literally daily basis is the BNF. So the BNF is the British National Formulary. It's a little A5 paper book. It's bright yellow at the minute. It's also available online as well. And this provides, it's often referred to as the Bible for sort of doctors, pharmacists and other healthcare professionals. So it provides a summary of doses, side effects, cautions, so reasons why you might sort of be cautious about prescribing something, and it also lists interactions. And everything in there is covered, so all UK licensed medicines are in there. So what the BNF currently says, Dr. Chris sort of highlighted this to us in his previous session, but this is the current sort of prescribing information that's there in the most recent, so September 2016 BNF. So it highlights the current dosing schedule, which I'm sure we're all familiar with. So this 1 milligram 3 times a week for 2 weeks as a loading dose, then a milligram every 3 months. It differentiates between pernicious anemia with and without neurological involvement. Now, interestingly, in September, I spent some time in the Royal Pharmaceutical Society library. So I literally spent time, I've looked at every single BNF that has ever been published in the UK, right back to the national formulary, which was around the time of the Second World War. And the dosing schedules have changed over the years. The additional information has changed over the years as well. So I started digging down a little bit more. So how do we actually determine, the dosing schedule that's in the BNF? So, you know, as healthcare professionals, as patients, how can we be reassured that what's in there is actually the most accurate and the most sort of optimal treatment? So on investigation, the way that those doses come about, so researchers, so people, there's a big sort of organisation of people based at the Royal Pharmaceutical Society. They will collate evidence. So their first port of call are the manufacturer's summary of product characteristics. So these are, again, a legal document that every product in the UK has. So every product in the UK has to have an SPC and a patient information leaflet. So these determine, so these sort of lay out exactly what the licensed conditions of that medication are. Okay, so it sort of summarises all of the information that company would have had to submit to get their product approved. So they'll first of all look at those. They'll also look at guidelines from expert committees, such as the BCSH guidelines. They'll have a look at published journal articles, and they'll look at other sources. So these might be sort of expert opinion, audit work, and other things like that as well. And then essentially a large multi-professional committee will consider all of this evidence and come up with a decision. Now, because there are so many drugs licensed in the UK now, they don't do this for every drug twice a year, because the BNF is published twice a year. So what they do, they'll review all of the drugs in there on a rolling basis, or if some new evidence becomes available, then that will bump it up to the top of the list. So that's how all of that information sort of comes about. So that's sort of where we are. That's why we're where we are at the minute. That's why we have the guidelines that we've got. But what I was interested in as well is, okay, so what actually happens in practice? If potentially we've got some scope to approach the editors of the BNF and say, can we look at you sort of reviewing the dosing schedule for vitamin B12 injection? I thought it would be useful, and so did Martin, that we actually find out what happens in practice. Are GPs, are prescribers actually willing to go outside of these recommendations? So over the summer, we did a survey of Pernicious Anaemia Society members. So we had about 271 responses in the end that we could utilise. So unsurprisingly, 92% of members report that their symptoms return before their next B12 dose is due. And interestingly, 60% of those people do have a GP that is willing to give B12 injections more often than every 3 months, which I find quite heartening. Of those, so 65 people that are receiving 2 monthly injections, but only 30 of those have neurological symptoms. Therefore, there's 35 of those patients that are having it 2 monthly are having it sort of outside of the BNF recommendations. So, It's a little bit small to see, I'm afraid, on the slide there, but we started to say to people, okay, so what frequency do you actually have these injections? So these are people that have them more frequently than every 3 months. So the biggest group there are people, so like I said in the last slide, about 65 people are having them every 2 months, which is good, and then there's 35 people are having them every month. There's another sort of significant group of people that are having them every 6 months. So you can see on there, there's a whole range of people on there. There's a small number of people that have them as needed every couple of days. There are a few people out there. But the most common group of people having it more frequently than 3 monthly is people having it every 2 months. So we also asked you, okay, for those people whose GPs were willing to prescribe it more frequently, what was the key factor, did they think, in influencing their GP to approve more frequent injections? And it was quite simple. It was you as the patients. So 51% said it was information that they themselves took along to their GP and provided. 13% said it was their own persistence, okay, them not being willing to accept, no, you know, you're fine, you've just got to keep managing. 23% of people were backed up by a hospital consultant. So their hospital consultant wrote to their GP and said, please consider giving this patient more frequent injections. But please be heartened that, you know, the most significant factor is yourself as an individual patient. We also wanted to look at what actions other people took as well. So my concern with my pharmacist hat on, I am also a pernicious anemia patient, but with my pharmacist hat on, I was concerned that there could be potential increased risks from people self-treating. I know as patients that often you may well feel that you have no other choice, but I think as a health professional we need to be aware that people are doing this and we need to look at what it is that people do. So 44% of people that responded said that they took additional B12 supplements to cope with the return of their symptoms. People used all sorts of different formulations, sprays, patches, self-injections, nasal sprays, all sorts of different things. The most common forms that people used themselves were sprays and self-injections. And how often people did it, that varied very much from whenever they needed them to about every 2 months. And then the next question was, so these additional B12 supplements, where do you actually obtain them from? Because again, there are potential risks out there to patients from obtaining them from somewhere where perhaps you can't be assured of the quality or the safety, or even whether that product is actually going to do what you want it to. So the largest number of our patients accessed, sort of obtained their supplements, additional supplements from UK online-based suppliers. The next group of that was people that were purchasing them from high street health food shops. But other people were purchasing things overseas online, so I'm presuming those are the people that are purchasing injections to self-administer. Other people were getting them from visits abroad, so sort of walking into a pharmacy abroad and buying them. And then a small number of people were going to a private clinic to get their additional supplementation. So considering all of that information, it's really what we intend to do with it. So we do want to collate all of this information together and formally present it to the editor of the BNF. So we want to highlight the lack of a robust, reliable evidence for the current recommended dosing schedule. So I've contacted the manufacturers of these products, so the UK licence holders in the UK. They are unable to provide me evidence for their dosing schedule. Now, as a pharmacist, I have to do this on quite a regular basis. If I'm trying to get down to the nitty-gritty of why is this drug prescribed at this dose, normally manufacturers will give you reams of information. Okay, they haven't been able to give me any at all. Okay, so we've highlighted that there is inconsistency of practice of GPs. Okay, that's not necessarily a bad thing. It's good that perhaps for those of us as patients that some GPs are willing to be a little bit flexible in terms of what they prescribe. So some are willing to prescribe injections more frequently. But also I want to highlight patient experience as well. So highlighting that many patients are needing additional supplementation. And as the NHS, we are failing these, a significant number of pernicious anemia patients. We are potentially exposing our patients to risks from obtaining supplements outside of the NHS. I appreciate that is, what many of us feel the need to do, but I feel it's important to highlight those risks and to highlight that the NHS is failing this group of patients at present. So that's what we intend to do. I'm not saying that this is going to be an easy task, but we need to start from somewhere, and hopefully the evidence that we've collated will be a start. Okay, so hopefully that's sort of highlighted the work that we've been doing. I'm quite happy to take any questions from anybody for a few minutes if there's any questions, and I will be around for the whole day.
I'll be around with the mic. Thank you, Dr. Wood.
You mentioned there's no evidence base that they were provided with when they come to, like, I think it's the SPCs or that sort of information. How have they ever got to that point of allowing it then, if they can't provide it to anybody that, especially medic, not as you in your role? How does that happen?
I mean, I have done a thorough literature search as well myself, and there are some very early studies. When vitamin B12 was first licensed, there were some very early studies that you can see how vitamin B12 got a license initially. However, there aren't strong studies. So when we're talking strong studies, we want large numbers of patients that are followed through for a long amount of time. A lot of these early studies were looking purely at bloods. So they were looking at blood markers. They weren't looking at symptoms, for example. So these early studies were in very small groups of patients. We're perhaps talking 30, 40 groups of patients. And when you think of that as the proportion, the percentage of the total number of people with pernicious anemia, these are very, very tiny studies. I doubt that if these studies happen now, if pernicious, if B12 didn't exist as a treatment at the minute, I doubt it would be able to get a license, because there just isn't that strength of evidence. There's certainly no evidence at all for the current dosing regime.
So going to the BNF, and they're obviously working together at somewhere to come to guidelines for treating patients. How did that ever get into the BNF, for example? If it's really that lacking in...
Yes, those dosing recommendations are there in the summary of product characteristics. So these products got licensed, and the BNF, that is the first sort of place that the BNF would go. It's always very unlikely that what it says in a summary of product characteristics won't reflect what's in the BNF and vice versa. It is such a grey area, and I must sound like I'm being really vague, but that's just because there just isn't that information out there. And as a health professional, I haven't come across this for other treatments before. So I'm just as frustrated as clearly and incredulous in some respects as probably many of you are here.